to now do passive physiologic intervertebral movement. We'll do flexion, we'll do extension, we'll do side bending, and rotation to both sides. And we're going to be evaluating for same old. Quantity, quality, and feel and tissue reactivities. Come a little closer. Now, one of the things you're going to notice with the woman's pelvis, not so much with the male, is that because of the wider pelvis of females, they are naturally going to be side bent to which side? The bottom or the top? To the top, right? So they are not starting from neutral. Keep that in mind. So you may want to put a towel roll underneath the bottom just to put the spine in its neutral position because of the pelvis. Yeah. All right, so here's what we're going to do. Straighten the bottom leg. We're going to palpate. Again, we find the iliac crest, takes us down, the intercrestal line takes us, in most people, to 4-5. In some people, it takes you to a different segment. It could be 3-4, where the lumbosacral junction is a little lower in the pelvis. But for most people, it takes you to 4 or 5. If you're not sure, you can mobility test, which we're going to do now, and see where the motion stops. And where the motion stops is the lumbosacral junction, because you should not be able to palpate motion between S1 and S2, should you? The sacrum is 5 fused vertebrae. But let's say that someone has a rare condition called what? Where you do have motion between S1 and S2. Anyone know what that's called? Not sacralization, but lumbarization. They have an L6. So they have motion between S1 and S2. That's rare, but you may have that. Assuming that the sacrum is all fused, the last segment that moves is 5-1. So that's another way to do it. So I'm going to start here with the premise that this is most likely 4-5. And I'm going to go down 1. I'm going to use her knee on my top of my thigh with my hand underneath, and I'm going to rock back and forth, inducing flexion. And I'm opening up the space between L5 and S1, separating the spinous processes. And I'm feeling that gapping, that opening up and through there. Now again, if I have any doubt, I just go down to the sacrum to see what's happening with the sacrum. Yeah, it's not moving, it's fused, it's fused. Where does it start to move? Right here. So I know through motion I'm in 5-1. You test that in flexion, you can test that in extension, relax, drop down. You get the last mobile segments. That confirms that you are in fact at the lumbosacral junction. So you can start with the crest and then you can confirm it. So you drop the knee down a little bit, and again, a table that can go up and down is really useful here because everybody's at different heights, so you're going to need different table height. This table works okay for me. So my middle finger is between 5 and 1, and I'm assessing the quantity, the quality, going to the end of range, seeing if it has a little give and play, and any reactivity. Then I go up 4-5. I'm using the hip to recruit the lumbar vertebra. Come under the ankle here, but I'm just my body mechanics. I'm not working hard at all. My lumbar spine is in neutral, and I'm just hip hinging, moving at my hips. Up to 3-4. And you want to start thinking, how does this correlate to what you saw with active movement? When you observed flexion, and you saw maybe there was more motion at 3-4 than at 5-1, is that what you feel under your finger? Do you feel more mid-lumbar flexion than lower lumbar flexion? Yeah. And you're going to grade it. 0 through 6. 3 normal, 2 slightly hypo, 4 slightly hyper. You know the scale. Go all the way up to L1, L2. If you want to do TL junction, you can do that. A lot of back pain comes from T12, L1. That tends to be a little bit hypermobile. So you can go right up to that. So that's flexion. The extension is a little tricky. I have 2 ways, and in first edition I just have the one, but in the second edition I put in the alternative approach, which I like. I'll show you that. So I find 5-1, and I use the hip, drop down, and I extend the hip to flex the sacrum, to nutate the sacrum, which flexes 5-1, and then flexes 4-5, and flexes 3-4, right up to T12. The alternative is really nice. You just come in, straighten your bottom leg. Extend. Sorry. The alternative is nice. You just come in under the waist. Like that. See my hand? And I put this palpating finger on 5-1, and I pull her waist towards me. And I get the extension that way, very little effort. 5-1, 4-5, 3-4. And again, I get to this point, and she says, it hurts a little bit. Two possibilities. It could be end-range pain from a dysfunction, but it could also be hypermobility. So I'll do the prone instability test to see which it is. 3-4, 2-3, 1-2. Pulling into extension. So there's lots of ways. You know, I wrote the preface. I like with the books, I get a chance to go back and put some philosophy together. And I say really, the techniques are secondary to the principles and the concepts. Once you understand what manual therapy is all about as a system, and you think as a manual therapist, the techniques you use are based upon your preference and your style. So let's not worship a technique. Say, he did it this way, I've got to do it just like that. No, that's not what it's about. You can modify it based upon what works for you. And it's not the technique, it's that you're getting the job done. All right, so that would be extension. Side bending, come over towards the end. You have two ways. Again, you have one way in your book, but here's another option which I have for you. I can grab under the ankle. Now I'm going to use the legs to induce the side bending. So side bending, we palpate on the ipsilateral side. So this is side bending the left. So I'm going to put my palpating finger between 5 and 1 on the left side of the interspinous space. So now I'm going to do this to the lower limbs to get the side bending left. 4-5, 3-4, 2-3. This could be tough. If you're 95, 100 pounds soaking wet, and your patient's 250, or what we heard this morning was what? Good Sam, 400? You're going to have a problem with this. But think about your mechanics. You got one body there for your whole career, so keep your lumbar spine in neutral, use good body mechanics, and palpate the uppermost side for an approximation. Or you can come in like so, on the hip, palpate on the ipsilateral side, and then induce the side bending like this. Like that. Drive the hip up. I'm on the trochanter, and I'm closing the left side, feeling with my palpating finger. Okay? And then rotation. Let's have you square on the table. Straighten your bottom leg. Okay. I'm going to come in through the top, and I'm now going to start from the top down. So 4-5, 3-4, 2-3, 1-2. Between 2 and 3, rotation is contralateral. So if she's rotating left, I'm going to be on the bottom side. And I'm going to induce rotation from above. You don't want to be straight at a right angle like this. You kind of feel that's the best, but you're better off coming in, pushing off your back foot. I'm pushing off my right leg. Coming in through here, and I'm rotating, pushing through the shoulder girdle, palpating underneath here, almost giving a little assist here. I'll show you a thrust technique for the lumbar. We're actually thrust through this arm a little bit if you feel there's the need for it. Coming in 1-2, 2-3, 3-4, 4-5, 5-1. Feeling on the bottom side. There's lots of ways to do this. Lie on your stomach. I can come in here. So here's something to think about. If I take her towards me, what rotation am I inducing? Rotation left or rotation right? It's always the rule of the superior vertebra. So if I take her hips to the left, I'm rotating, if I'm at 4-5, I'm rotating 5 relative to 1 is going into left rotation. So I'm on the right. 4 relative to 5 is left rotation. So that's left rotation. I'm looking at the top vertebra on the bottom. See? I'm taking 5, I'm taking the sacrum rather, in rotation to the right, but 5 is relative to the sacrum is rotated left. I'm taking 5 to the right, but under 4, 4 is rotated left. So this is left rotation. Now I'm palpating on the right side. Really easy to do this. There's so many different approaches. Side bending, I can do this. I can come in, relax. Coming on this side, I can do this. 5-1, 4-5, 3-4. This was the biggest, I mean, what's big now for you guys in terms of clinical prediction rules, regional interdependence, core stability, deep neck flexors. What was big when I was in PT school was Stanley Paris's mobilization. That's what everybody wanted to learn. They wanted to learn how to palpate 5-1, 4-5, 3-4 restrictions, and then mobilize and manipulate. There was no sense that maybe we were making joints hypermobile. We just had fun mobilizing the spine. And we realized that there was a lot more to it. So you see how I'm just creating a technique here? And you can come up with all kinds of options. I'm on the left. I'm assessing 4-5, 3-4, 3-2, side bending left. I'm just trying to get specific. So you have someone you can see actively, there's limitation, but you want to find out where is the area of greatest restriction. That's where we're going to mobilize. All right, thanks. So you just got to go play with it. Flexion, extension, you have two side bendings, rotation. You just start to feel between the spinous processes. Not easy, I'll tell you that. It's a very small space, and you're going to have to almost imagine in the beginning that you're feeling something, because you're not going to totally make the connection with what you're feeling. So, play with it.